Good afternoon. It's great to see so many live people in a room. Who would think you would have said that, right? And great to have however many people there are on Zoom. Someone knows, but not me at the moment. Okay. 44 people.
Recording in progress.
I have to mute the stereo. My name is Karen Glanz. I know many of you, but not everyone. Together with Dr. Steve Joffe, who's here, we co-lead the cancer control program at the Abramson Cancer Center. And we are sponsoring, together with the Department of Medical Ethics and Health Policy, this seminar today. And I'd like to welcome you and introduce our speaker. This is, can't see you even because this is not a short person's monitor. This is a second talk that we've been privileged to have with Dr. Jonathan Jackson from Mass General Hospital and Harvard Medical School. Jonathan is the Executive Director of the Community Access, Recruitment, and Engagement Research Center, acronym CARE, at Mass General Hospital, and he's an Assistant Professor of Neurology at Harvard Medical School. Having gotten to chat some with Jonathan over the last day or so, he has a really interesting background. He's trained in neuroscience. His work has been funded by the Michael J. Fox Foundation, National Institutes of Health. He's received an NIH Pioneer Award, which is very prestigious for those of you that aren't familiar with that, and has his doctorate in psychological and brain sciences. And he has morphed into very much of a community engaged, health disparities, ethically oriented expert, and has done some really interesting work and is continuing to do that right now. So today he's going to talk about the challenge of quantifiable research representation. And if you have questions, put them in the chat. We will be monitoring them and we'll ask them at the end, and turn it over to Dr. Jackson.
All right, good afternoon, everybody. And thank you so much to Dr. Glanz and Dr. Joffe for inviting me for two talks and not kicking me out after the first one. So I'm still here. So maybe that means that something went well yesterday. We'll see if we can continue the streak. No promises. So yesterday's talk, just for those of you who weren't here, was really focused on a lot of the ethical challenges when it comes to thinking about research participation in clinical trials. There is a deep and extensive history of medical abuses. There are contemporary issues of neglect. So I wanted to just acknowledge that since I spoke so much about that yesterday, that won't be a feature of today's presentation. However, that is the background, that's the backdrop against which I am operating. So with that said, I'm gonna go ahead and get started. Today's talk is just as chock full of goodness as yesterday's. And what I want to do is find a slide advancer that works.
Oh, and try again.
There we go. Thank you. So my disclosures are listed here. They're a little bit more detailed, not because I have anything particularly strange to hide, but I just figured you should know where my money's coming from now, where it came from previously. I don't think anything on here is particularly nasty unless you want to count something, coming from Mass General Hospital or something like that. They don't pay me enough to lie. So what I want to do is start off by talking a little bit about the frame of equity and representation in research. I think I'm just going to assume that we are all in agreement that it is good to have diversity. It is good to have representation in your clinical work, in your clinical research, and without it, that you're doing, say, kind of a vaguely morally bad thing. That is great. That is not what I'm going to be talking about today. I want to talk about this from a scientific imperative, because when we can talk about it from a scientific imperative, it becomes much easier to understand, not only some of the things I'm going to be talking about today, but why and how we can integrate better inclusive practices within our existing workflows around clinical research. So I wanted to just give you a refresher about the 4 fundamental validities. So hopefully you can cast your mind back to undergrad and remember that there's internal and external and construct and statistical conclusion validity. And with those 4 validities, you basically have the founding principles for causal inference, cause and effect for most of science, but especially for human subjects research. Now, without representation, without representative populations, you are risking not just 1, not just 2, but all 4 validities are under threat. When we think about lack of representation, sometimes we'll say, okay, well, maybe it will reflect generalizability, so that I might take a hit to external validity. Maybe if there is some sort of differential item functioning going on with our assessments, that construct validity may be undermined. But it's really important to recognize that statistical validity and internal validity are just as sensitive to a lack of representation in our research. So it's not just that you need to have diversity in your samples so that the little brown folks get help too. This is how you actually conduct rigorous and effective science. So if you don't have that representation, the conclusion is you're not doing science. You're doing something, it's not science. So let's talk about current efforts in diverse recruitment. So if you fail to achieve a representative diverse sample, what does that look like? What happens? So I alluded to this particular paper yesterday. So I challenged myself yesterday to not present this data point because I presented it at every talk over the last 3 years, but I'm going to present it today. So this is not my paper. I'm not an author on it, but this comes from Carrie Gleason and her colleagues up at the University of Wisconsin-Madison, who looked at all of the data that you collect from the Alzheimer's Disease Research Center. So you get a few thousand subjects together. And what you do is you look at whether those individuals are more or less likely to progress from either baseline of no cognitive impairment to having some sort of dementia. And so what you can see here is if you compare white people and Black people at baseline, you can see that if they're unimpaired, there's not necessarily a whole lot of differentiation between that rate of progression over time. So first of all, this is a little bit odd based on what we know in terms of risk of dementia as a function of race. The thinking is that if you are Black identifying like me, that you are somewhere between 2 and 4 times as likely over the course of older adulthood to develop dementia. So this is strange, but maybe there are some reasons that might explain this particular data point. Where things get really squiffy is when you look at individuals who have mild cognitive impairment at baseline and who progresses to frank dementia over time with that particular diagnosis. And so what you see here is something that would make you kind of say, huh. And what you see here is that white individuals are progressing at a far faster clip relative to Black individuals. And so this is such a dramatic data point on the right that you might think that maybe the authors mislabeled the graph. Like if it was flipped, maybe that would make more sense. But it turns out that basically this is nonsense. So the problem here is not that there's anything wrong with the data. This is exactly the data that's reported in one of our largest data sets related to Alzheimer's disease. But it turns out that they have this relatively simple figure that they published in the paper that talks about why the data turned out this way. And it's something that's known as the healthy worker bias. I don't know if anybody's familiar with that particular concept. But essentially, you have a high-risk group, Black people, that are being recruited from a low-risk setting, which is just out in the community, where you've got a relatively low-risk group that are being recruited in a high-risk setting, which is that is to say, the white individuals are coming from memory clinics. So if all of your white people are coming from memory clinics, where there's going to be a high rate of progression to dementia, because otherwise, why would they be there? And then all of your Black people can't get into those memory clinics, so you're getting them from the local Black church up the street. Then what you've got, instead of necessarily comparing white people and Black people, you've got apples and oranges. And so this is the current state of diverse recruitment for clinical trials. anytime you have FDA or NIH exhorting that you have diversity in your samples, what people go out and do is they end up with two different recruitment streams, and they're recruiting two different populations. And they say, well, you've got darker skin, so you're in the Black group. You've got lighter skin, so you're in the white group, and we're going to make some comparisons. Unfortunately, this is not good science, and we're going to kind of walk through why that's the case. Now, I want to give a thornier example of this, because I used to say this is what happens when you fail to have diversity in your research sample. And so now what I'm going to do is I'm going to walk you through a much more embarrassing example. If you look here in the corner that says Jackson 2017, this is my paper that we're about to shred to pieces. What we've got here is, the long and the short of it is that if you make these mistakes, if you do this poor kind of analysis, not only is it not science, you are really likely to get published. So what I've got here is a comparison of objective and subjective memory in a cohort of older adults. So what we did was we matched white people and Black people. I bowed to kind of public pressure at the time, and I called them African-American, even though I'm pretty sure there wasn't a single African-American in our Black population. And so what you find here is that where you see that subjective cognitive concerns tend to increase as memory performance decreases for white people, making it a really nice biological marker, or I guess a behavioral marker of memory performance. You see that there's virtually no correlation between subjective and objective memory for Black people. This is a really cool finding. And what you have here is, if you actually go and look into the correlation among the composite scores, you see that there's great internal correlation between the subjective and objective measures for both white and Black people. But for the Black group, for some reason, subjective is just not correlating with objective. And so what you have here is like a really fascinating breakdown that may call into question, the construct validity of the way that we understand memory. But this is a terrible paper, and you shouldn't believe anything that I just said, even though it's my paper. So if you actually look at the breakdown of the data, so what we ended up doing was we tried to match on age, education, and reading ability, which is exactly what you would normally think that you should do. But unfortunately, in matching for that sample, we sort of created some other problems, like we became relatively unmatched on something that may affect subjective cognitive concerns, or that ability to report, which is to say that the matched sample of white folks that we have in this paper, which again, bowing to public pressure, I called it Caucasians, never again. But the geriatric depression scale you can see is now no longer matched between individuals, and may mean that what we're seeing here is just a decoupling of subjective and objective memory, not because of race, but because these individuals are, they may have some sort of some sort of threshold level of dysphoria that may be skewing the way that they're reporting subjective cognitive concerns. So that could be true, but 1,000 other things could be operating here. But what I am here to tell you that is not likely to be the case is that it's not likely that there's a decoupling of subjective and objective memory because of the amount of melanin in someone's skin. So the paper goes on to make wild speculations about why this may be the case. I actually wrote an entire follow-up that replicated this longitudinally over time. And we saw this dramatic effect of Black people who were amyloid positive, showing a much steeper rate of decline relative to other groups. But there were only 6 people in that cell. And so what you have here are data that are unlikely to be replicated and are highly unreliable. But we're also making the huge mistake of kind of attributing a lot of causal factors to someone on the basis of their racial identity. And it's just unlikely to be anywhere near effective or good enough. So instead of thinking about diversity as something that we should strive to attain, we need to think instead about why diversity is important in research. And so what I would like to challenge you all to do is, instead of saying, I need to attain, this proportion of this, this kind of person in my study sample, instead thinking about the lack of that representation as a little bit of a signal, maybe, like a little finger going up and being like, hey, maybe you need to pay attention to the way that you're collecting your data. So what we are in danger of making the mistake of is sort of saying that, and this is what I did in my paper that I hate, is you sort of reify race as some sort of essentialized or biological driver of difference between people who look like me and people who don't. Now, what we know to do today is to say, well, it's not all biology. We know that there are social and structural factors that also play a role in this as well. And so maybe a better approach would have been to say, well, there may be some biological factors, but there could be some social or structural issues as well that could affect it. However, what I'm going to sort of posit to you today is that this is also insufficient. Because as scientists, as researchers, we need to do a little bit more in terms of like cleaning up our own house before we can attribute things to the world outside or to Black people's changing bodies. So what we've got here are 3 additional sources of variance or sources of bias that are worth exploring. So instead of just looking at social and biological factors, I would really encourage all of you, no matter what kind of work you're doing, if it involves human subjects, to consider particular aspects related to selection, measurement, and implementation. I'm going to give you plenty of examples of each over the course of the rest of this talk, but these are factors that I believe, or at least my hypothesis, is that you have to address variance in these 3 factors before you can start making wild accusations about social and structural factors or about biological disparities. So that really raises an important question. What should we do with race? These are slides that I was originally set to present yesterday, but I ran out of time. So I stuck them back into these slides here because I really think this is an important question. What should we do with race? I keep talking about how important diversity and representation is, but now I'm saying, well, race is not super important. What are we supposed to be doing with it? So we know that when it comes to Alzheimer's disease, which is where I spend a lot of my time, race or ethnicity is thought to be some sort of risk factor. And it's usually attributed to some kind of vascular factors, ? We don't really know, but that's what people say, so we all believe them. And so when we use race in our research studies, we're probably doing it for one of the 3 following reasons. We are trying to do some sort of dimension reduction, right? So we are trying to say, we think race stands for all of these social things, and so instead of trying to measure or capture or understand, maybe some sort of latent variable behind that, I'm just going to use race because it's quick and easy. We might use it as some sort of proxy. So we might say, well, I don't have enough money to do ancestry informative markers. I also don't know how to interpret that data, but you know what I do know how to interpret? Race. So, check that box. We also may use it as a marker for racism, and this is becoming increasingly common. So we can say, oh, yes, we stroke our beard and we say, race is, a social construct. So I'm going to use race, but not for race. I'm going to use it for racism. And so we're going to use that as, again, a kind of proxy to talk about selection effects or healthcare access or other sorts of environmental or social exposures that may be disproportionately borne by some people relative to others. These are all reasonably defensible reasons to use race. And I would argue that in that awful 2017 paper of mine, we were using it as some very vague version of all 3 of these things. Unfortunately, and here's where I'm going to make my strong argument, you should never do this, ever, ever, ever. There's no good reason to ever be using race as any sort of a grouping category in our research studies. I'm seeing some narrowed eyebrows, so we're going to get into it. So you might be, wondering, what does that mean? But let's walk through what this means. So if we are going to try to use race as some sort of construct, we're going to say that this might help me understand something socioeconomic about these poor singing folk. What we need to understand is that, first of all, the categories of race usually lack any kind of empirical definition. They're famously resistant to any kind of quantification, and they tend to be relatively poorly correlated with a lot of the socioeconomic factors that we are looking for, at least in terms of preserving the level of variance that we need to find a signal in our statistical models. So if we try to rely on race, we tend to have a huge hits, not just to external validity, but also internal and statistical conclusion validity, because it is not a very good proxy of the things that we are actually interested in. Now, if we try to use it as some sort of a variable, we know, or we should know by this point, that racial identity is not a great way, and it is not particularly well correlated with genetic variation or ancestry. Again, because it's a social construct, why would it be in many ways? And so we also have to recognize that even if it was, if you're going to tie something to racial identity, you are usually beholden to some variation of the US Census reporting. And then the question becomes, which US Census are you going to use to make that determination of racial identity? Because in 1990, you couldn't necessarily indicate that you were more than one race. In 2000, you could, but you could only indicate that you were more than one race. And everybody who did that got swept into one big other category. In 2010, you could check more than one box, but how do you do that in terms of intersectional identities? And then in 2020, we know that's a horror show. We just saw like all the new data that said that everything was horribly underreported, especially for a lot of those racial and ethnic minorities that we're trying to count. So which US Census are you going to do? Which set of sort of thorny political situations are you going to count? If you go even further back, then you run to the question of who gets to count as white. Because obviously, because of a lot of anti-Black views, you know, the category of white is sort of ever shifting and expanding. So again, race is not a stable construct. Over time, it is not necessarily even good when it's pegged to something like the US Census. Now, as an indicator of racism, what it tends to do is it tends to put the focus on the individual who's experiencing racism rather than the systemic factors that perpetuate that racism. And usually in our models, if you want to maximize variance, you need to go directly to the source rather than some sort of watered down proxy. And so we need to focus on the barriers, focus on those exposures rather than individuals. And so unfortunately, relying on race as a marker of racism creates deeply misleading monoliths. Because not all individuals who identify as some sort of ethno-racial minority necessarily experience racism in the same ways. And so you don't want to oversimplify, because again, from a statistical point of view, you are throwing away variance, or at least you're rolling it into your error term. So again, there is a great moral argument never to use race, but these are the ones that, you know, that kind of maximize the scientific theory. Okay, so as I've said, you should not be using race in your models. So you might be saying, hang on a second, I shouldn't use race in my models, but we need all this diversity. How am I gonna do that if I can't do, it doesn't seem like they don't fit, right? It doesn't make sense. So just bear with me, all right? I'm gonna walk you through it. So think about your mechanism of action. Be as specific as you can be. So, you know, if we're talking about race, you know, unless we're talking about pulse oximeters in which the melanin in your skin does matter in terms of determining reliability, it's really not going to be, the color of your skin. There are going to be consequences of that you can try to approximate through a whole host of other really well-validated measures, usually ones that are better quantified, ones that have better issues with regards to a less restriction of range and better variance for predictive modeling. So do your best to measure whatever that mechanism of action that you think it is, or that environment or that exposure, instead of relying on race. So there are also lots of more useful group differentiators. You might be more interested in access to care, or rurality versus urbanity, decisional authority, health literacy. But the one thing that I also want to say is you have to be careful about your referent groups. So not only should you not be using race, but if you do use race, you should never be using white as a referent, because why? Like, what does that mean? What is sort of assuming or normalizing? Again, these are crutches. And frankly, in this day and age, it's a little bit lazy to be relying on these things. We have better tools available. And in many cases, they're going to be much more rigorous and useful for the questions that we have. So you might, for example, consider one of many standardized sets of social determinants that may be leveraged to try to help you get at these sort of latent variables that may be behind racism or dimension reduction elements of socioeconomic status. And what's great about these social determinants is that it allows you to start to create and construct really great intersectional variables. Because again, one of the problems of race is that if you see somebody through purely the lens of their racial identity, or purely through the lens of their, say, their gender identity, it again leaves a lot of variance on the table because you're missing out on the other aspects of their identity that do have some bearing on those health outcomes. Leveraging something like a standardized set of social determinants allows you to preserve the variance from multiple aspects of identity, which means you can have a richer hierarchical data set that preserves all of that rather than reduces it for the purposes of simplicity. It also makes things like trying to design recruitment plans and execute them. It makes it much easier when you have a clear idea of who it is that you're trying to reach. So race is not a third rail. I've lived in Boston for 10 years, where it definitely is. But it can really help you see that there are lots of issues when it comes to the way that we design our recruitment studies. But ultimately, what I'm here to say is racial identity can only ever be a marker of racial identity. Don't use it to stand in for anything else. It's doing enough. Lord knows it's doing enough. But if we want to be good, robust, statistically relevant scientists, we will leave this by the wayside as soon as we can. It is not always easy. In some cases, it just isn't possible because of the data sets that we're limited to. But if you are using race, know that you cannot trust the data that you're getting out the other end. I would not necessarily encourage you to do any sort of interpretation. So if you can't remember all of that, remember the Drake rule. Using race as a marker of group differences, but using specific exposures and mechanisms as a marker of those group differences, now that is something that I can get down with. All right, so this is the Drake rule, and this is the kind of the entire point of the talk. So I'm just going to reduce it down to this. I will share the slides, so please print this out and use it liberally. Okay. So Lasagna's law states that the incidence of patient availability sharply decreases as soon as you start a trial. And then when you're writing your next grant, or when you're designing the next study, it goes back up to that original level. Now, another way of saying Lasagna's law is that we as principal investigators have no idea how recruitment works. We don't know how it's going to go. We sort of make up a best guess and sort of leave it to our trusty research assistants and CRCs to kind of pick up the mess. But it really gives rise to, I think, a really interesting question. Why can't we recruit diverse populations to research? Why can't we do that? Why is that so hard to do? So I don't do a lot of cancer work. I do just a tiny bit. Back in 2016, I wrote a commentary with a couple of colleagues of mine in like a weekend. It was actually really great because there was this really interesting study published by Sao and colleagues in that same issue that tried to recruit for a prostate cancer trial for Black men. They left enrollment open for 3 years and 3 months and only enrolled 11 individuals over that time. And so what was really interesting is they thought they had done everything right. They had opened, recruitment at 2 centers that had catchment areas that had a large Black population. They were among the people, but they couldn't find more than 11 that fit the criterion of the trial in that 3-year period. And it wasn't just a matter of eligibility criteria. If you go back and read this article, as well as the entry on clinicaltrials.gov, you can see that it wasn't a matter of screening. It's not like they screened hundreds and only enrolled 11. I think they screened something like 13 and enrolled 11 of them. So if they were in the hood, as it were, they were at these cancer centers that were located within these Black populations, what did they do wrong? This is a picture that I took. This is 2017 in Boston. There was an event on memory loss that was held every year, and hundreds and hundreds of people attended. So then the local chapter of the Alzheimer's Association fired the guy that did it, and they said, we're going to do it ourselves. We'll do it ourselves, like in that, we'll use the local Kroc Center. So this is the Kroc Center in Boston, Karen.
Jason.
And Jason, if you're online. So what happened was we're going to do it. We're going to design it. We're going to scale it down from 500. We'll just design for 300 people. So I get there because I was a speaker for this event. I did not organize it. This is the entirety of the attendees. This is literally everybody that was there. One table. They all sat at one table. And so they were outnumbered 2-1 by the catering staff, who you can't see or who are behind me in this picture. So this event was in the hood. It was at the Kroc Center. It was run by the one Black person on the Alzheimer's Association's team. Why couldn't they get people? They weren't recruiting for a trial. They were just telling people about dementia. Why couldn't they get it right? It's a really good question, and I'm going to give you some answers. So it turns out that it doesn't really matter what you're studying, it doesn't matter what you're trying to do. If you're trying to get people invested and involved, there are basically 11 reasons why you can't recruit. And so what is really difficult is that you don't necessarily know which of these 11 reasons are operating at any given time, which ones are intersecting, which ones are particularly a thorny problem, which ones are upstream or which ones are downstream. We just may note that some of these are factors, or maybe none of them are. It's hard to tell. And that is why recruitment in general is difficult, and recruiting for specific individuals is particularly challenging. So what that means is that if you're trying to talk about representation science as a field, it's really, really fragmented. We don't have clear definitions. We don't have any sort of bounded data ontology, or even really good comparative effectiveness models. Most of the articles that you see that talk about recruitment and diversity are really reporting case studies, and it's really, really tough to kind of replicate or generalize them. There are lots and lots of confounds here. We don't actually know what a minority is. Have you ever thought about that? We talk about minorities, but what is that? And how can that be sort of quantified and built into our recruitment plans, much more so like the models that we're trying to build? People don't necessarily know what they're talking about when they say outreach, recruitment, retention, and engagement. They treat them all the same. They have the same kinds of outcomes for all of them, but we know that they're different. And then ultimately, the infrastructure is non-existent. So there aren't really experts or tools or resources or trainings available in any way that's sort of generalizable or scalable. If you are study staff, you're never exclusively dedicated to recruitment. You're usually doing that in your spare time. And then all these systemic failures that we see, because these things should be managed by large grant organizations, they should be managed by institutions. They're either left to research participants, or even in the best of scenarios, they're left to individual study teams. We've got a systemic problem, but it becomes an individual element of responsibility. So if you are a young, enterprising recruitment scientist, you might have this kind of reaction. And believe me, this is me most days. But ultimately, what I think you can do is you can start to build a workflow that helps you tunnel through some of this noise. So we've got our top 11 reasons here. So what I would propose is that there is an ordered workflow of these barriers, such that you need to take care of the earlier ones before you can see any sort of difference made in your later ones. So some of these map on really directly, really nicely. And then, something like poor targeting of your catchment area, it turns out that if you don't try to address that as early as possible in your study, then it will be very, very difficult to have an effective intervention anywhere downstream. And so all of these actually map on really nicely into this ordered workflow that becomes sort of a recruitment funnel with these particular areas. And what's interesting is that the detailed protocols and SOPs that we build in clinical research only cover a third of these levels. Everything else is usually left up to privilege or literacy to navigate. And so it's no wonder that we have highly privileged individuals or highly experienced individuals that are able to navigate all of these stages and make it to the stuff that we actually do feel confident on. And so what's great about this particular model is that if you create a dedicated, thoughtful outcome measures at each level, it can also help you understand where you may have particular bottlenecks in your workflow. And if you have specific, well-identified bottlenecks, it becomes much easier to develop an effective intervention, because you're not trying to solve all of these problems at once. You're just trying to solve the one that gives you sort of the most bang for your buck. So in this particular model, you would want to try to maybe develop an intervention that focused on awareness, or was more thoughtful about your screening and enrollment process, because those are kind of the largest drop-offs that then end up creating downstream consequences in terms of who's able to participate in your study. So now I want to talk very briefly about some examples of these kinds of biases that I was talking about. So selection bias, which really refers to a lot of what I was discussing with that recruitment funnel. So in 2018, I was approached by the Michael J. Fox Foundation because they had an online study of Parkinson's disease. And they said, because it's online, because you don't have to go to a movement disorders clinic that are only in certain parts of the country, we should reach everyone. And this is who they reached. So if you're having trouble sort of seeing the labels here, this graph is white for a reason. So I'm going to have Bernie Sanders help us understand how we should feel about this data. And it turns out it's not just lack of racial diversity. If you looked at educational attainment, 1 in 3 of the 20,000 participants had a master's or a doctoral degree.
Oh my God.
The median income in the United States was $110,000. And so unless you really are arguing that only rich, overeducated white people get Parkinson's disease, this is not representative. And it's an online study, so something is going on here. Something is weird about the way the study was designed. So working very closely with the CARE's assistant director, Angie Sanchez, who at the time was a fellow with me, we designed something called the Fire Up PD study. And so that was really targeting these early levels of selection with the recruitment funnel that I just illustrated. And so we had a study that was designed to focus on these first 4 sets of barriers. And we really powered it just to try to understand what engagement looked like. We weren't even trying to recruit people for the study. We just wanted to say, recruitment's too early. We're just thinking about engagement. Can we change some of those minds? And then downstream, would we potentially be able to recruit them? We had a really broad definition of minority. So instead of just thinking about ethno-racial minoritized populations, we also thought about individuals who are not men, who are woefully underrepresented in the Parkinson's research literature, individuals of relatively low education or income, and in this case, low education means less than a college degree. Low income means anything lower than the median US salary at the time, which is about $55,000. And then rural residents, of course, were there too. So we had a really strong focus on that sampling frame, that element of sampling selection. So we wanted to understand, which of these minoritized individuals want to access this online platform called Fox Insight. And so we also required that everybody write detailed engagement protocols in the same way that you write detailed research protocols, so that we can understand whether recruitment was really a function of a single charismatic, underpaid RA who was driving everything, which is the cynical reason why all of this doesn't fall apart. So we had 8 sites. It was just a small pilot study for controlled. So we had every site identified a barrier that they were trying to overcome. They identified a specific population that they were trying to reach, and an intervention that would reduce that barrier for the specific population. We randomized individuals an intervention and control sites. It was a 5-month intervention. We gave $45,000 to intervention sites and $10,000 to control sites, which is twice as much as any other study in Parkinson's that had ever given people to work on recruitment. So we're not talking, millions of dollars here. And so the interventions that people chose, so we had every site develop their own bespoke intervention. It mostly fell into 2 kinds of categories. One, working directly with minoritized communities, and the other one working with usually primary care physicians. And so everybody had like a multi-pronged approach. So just to kind of spoil the punchline, instead of talking about the engagement data, we're actually going to talk about the recruitment data, which I said the study was not necessarily designed to make a difference in. What you see in gray here are baseline recruitment at these 8 sites to this Fox Insight digital study. So what you can see here is that the control conditions, which was a passive control, they were not supposed to do anything different, still saw a huge spike in non-white and Latinx enrollment. They didn't recruit anybody from this low income category, and they were able to match their recruitment rates for individuals who were low education, but were not racial or ethnic minoritized individuals. And so this is already kind of strange. How would a passive control that documented everything, that didn't do anything different, nonetheless have like a huge spike in enrollment for these populations? It gets more interesting because when you look at the control of the intervention condition, you see that these groups also had a huge spike. But this is one of those rising tide lifts all boats kinds of situations, because the individuals in these categories were white identifying. So not only were individuals recruited that weren't specifically targeted, it does seem that these bespoke interventions did reduce these barriers. Now, what's really interesting in this is that of the individuals who were recruited to the study, there were still 230, which you can't quite see. That's an N equals 230 at the corner. 230 individuals that wanted to participate but couldn't. And so we actually cataloged why people weren't able to participate in the survey or the study in any way. And so one thing that I want to point out here is the third one from the left, which is mistrust. And this has been reported over and over and over again, but it's really nice to see it in this particular data set, where we understand that while mistrust is a significant factor for lots of racial and ethnic minorities, it is not necessarily the reason why they don't participate. What we see here is language equity and the digital divide were far and away the biggest reasons why individuals didn't want to participate. So time commitment was also an issue. It turns out that one was mainly an issue for urbanized centers. Ones that were in suburban areas wasn't so much of an issue. People just didn't want to deal with traffic. And then this other category was actually disproportionately borne by control sites. And this is mostly cognitive difficulties. So usually this is somebody who is dealing with some sort of cognitive impairment associated with Parkinson's. But the majority of the reasons are about the digital divide and language equity. It's not about mistrust in the same way that we all often think it is. Mistrust is worth working on, but the bottom line with this particular data set is that the single biggest predictor of minoritized individuals participating in research studies was them being paid attention to and asked. And this has been replicated over and over again. It's actually in the recent National Academy's report on improving representative recruitment. So bottom line, usually there is more diversity than what you think, even within these like very highly specialized movement disorders clinics, which are neurology subspecialists. So they're really, really hard to get into. So even in that space, we might assume that it's all white and all privilege, but it turns out that it's not. And by simply paying attention to some of those social factors and standardizing the way that you engage with people, you magically end up propping up your diversity. So we're actually in the midst of designing a follow-up study. And we actually just kicked it off a couple of months ago. And I am lucky enough to have basically handed off the PI duties to Angie. So she is visiting all of the 10 sites that we have involved in the study across May and June of 2022. She's very busy. And we are coming up on the end of a standardized, harmonized engagement that we have designed as part of the study. So what's great about the sequel to Fire Up PD is that we have sort of standardized all of the things that are typically allowed to vary with research protocols. So we have really, really rigorously standardized that engagement and initial recruitment process, whereas we have allowed intervention sites to vary some aspect of that intake that they'll be able to do over a 6-month period later this year. So you'll have to invite me back. You have to invite me back so that I can give you kind of the lowdown on how this all turned out. Now, very quickly, I want to talk about measurement error. And a big problem when it comes to research representation is that we're not measuring the right kinds of things. So what we did was we did a small pilot study for a neuroimaging protocol called ADNI, where we did this at 4 different sites to try to understand how they were able to recruit the different kinds of populations that they were trying to recruit. And so what we ended up doing was we kind of came up with this 5-dimensional model of things and stuff that people should do. It's not quite quantitative, but so it's a little bit more of a qualitative measure, but it's really, really interesting because you can start to see that a site like Emory that's in Atlanta, of course, has significant kinds of community engagement and partnership. Another site, there's a little bit of a color differentiation issue here, but the next one is the University of Kansas, where you can see that they don't have that same level of community engagement, but they do have like a really great workflow to try to reach these minoritized populations. A site like Rochester, which is typically very, very good at recruiting very privileged white people, doesn't necessarily do anything other than have that tightly integrated workflow. And then you've got UCLA, which kind of does a little bit of everything. And so what's really interesting here is that you can leverage this to recognize one of two things. So first, there's a lot of variability in the way that different sites do a very standardized protocol. ADNI-3 is very, very standardized, but in terms of the recruitment, it's highly variable. And secondly, what you realize is that there may be more than one perfect way to do research. Not everybody needs to look like Emory to reach Black and African Americans. You can really maximize maybe some of these other dimensions to do well. And so you can actually create like a little miniature dashboard here where you can look at, say, the data that was developed by Rochester, and you can see, using this inverted funnel that I've kind of outlined here, where those bottlenecks are. So in terms of those minority individuals that were reached out, you can see that they were only able to engage 18% of them. And then of course, because these are zeros, we have no insight in terms of how well they would be able to engage these populations further. Now, let's compare Emory, on the other hand, where you can see that they have a really healthy rate of return at each and every level. And that is primarily driven by that, those expansive community partnerships. So I'm running low on time here again. So I wanted to kind of very quickly talk about one of our newest dynamic models. So the program manager at the Care Research Center, Helen Hemley, had a PCORI award looking at something that's called a theory of change. And so we often talk about stakeholder engagement and being involved in the community. And I think that among researchers who aren't engaged in this work, there's the assumption that a community advisory board is sort of the same no matter what you do. You have to do kind of the same process. But there are multiple different dynamic ways of doing stakeholder engagement. And so what Helen did with her theory of change project was, instead of saying, I've got a study that I want you to join, let's convene some stakeholders and talk about it. She convened stakeholders across all of these different sort of sectors and said, what do you want to do about research in general? How do you want to engage with clinical research? How do you want to be approached? How does your neighborhood and your community want to talk about these kinds of things? And so she actually had a really detailed process that she ran over the course of a year while she was on maternity leave for most of it, believe it or not, and was able to kind of develop these meetings to create some really, really rich qualitative data about what that research and engagement process should be for Black stakeholders in Boston. And so it's recognizing that there's a lot of this kind of parachute researcher mentality. We recognizing that there needs to be more engagement and ownership and cooperation. And so what they were also able to develop were these beautiful, elegant tiers of engagement. So it's recognizing that not all engagement activities are going to always be roughly equivalent, that some are going to be necessarily more productive, and some are going to allow you to provide more feedback that may be relevant or useful for designing research studies. And so they really ended up coming up with like very, very nuanced understandings of what research engagement looks like, and sort of an enlightening of that difference between us and them, between community stakeholders and research teams. And they actually developed what is called an outcome map, which is a very, very rich version of what you might think of as a logic model. It has a lot more details, a lot more deliberative and thoughtful evaluation plans. And basically with this outcome map, you have a detailed procedure for how to engage certain stakeholders within a community at a certain time, and how to know whether it's effective or not. So instead of playing the guessing game, you can leverage something like this process to get the kinds of information that you're looking for. Now, additionally, we need to recognize that there are key problems when it comes to sort of a systems or a levels of analysis approach. There are lots and lots of these factors that we have to recognize. But my really great colleague, Andrea Gilmore-Bykowski, has done this excellent work talking about building the relationships that are necessary to promote research participation. And so you can think of those as really adding a lot more nuance and detail to some of those middle levels of the recruitment funnel that I mentioned earlier. Okay, so I'm actually just going to stop there and see if there are any questions. I've got a few more examples that I'd be happy to walk you through, but I think that's probably enough for today. All right, so thank you very much. Sorry, what? Yeah, we can get rid of those.
We have 10 questions in the chat.
Oh,
Hey, Jonathan,
okay,
this
sure.
is fantastic talk, and maybe you can just take one from the room and I'll give you one from the chat and we'll go back and forth.
Of course.
I'll start with one. Well, this might be too big of a question, but I will ask it nonetheless. So
Okay.
Framing from yesterday and the beginning of today, the fact that we don't have diverse or representative participation in
Yes.
research,
Yes.
and illustrating that by showing the breakdowns by race, ethnicity in particular. We can show women. Often we have too many women in some of our research, at least in social behavioral research. How do you reconcile that with the race is not a real thing variable?
Yeah. So it's an interesting question because it feels like these things are at odds. It feels like if you want to have that representation, then you have to pay attention to a variable like race, but you don't. So there are lots of other ways. There are lots of other elements of social and individual identity that you can condition these analyses on. And so what I'm saying is that race is particularly problematic. Sex and gender are also problematic, but for purposes of today's lecture, let's go with like the elephant in the room. Let's talk about race. So there are lots and lots of other ways of reifying whatever it is that you're trying to get at with race using other measures. So you can use social determinants, you can use different kinds of environmental or individual or social exposures, and use those to kind of understand what kind of population that you're trying to sample from. So, in this day and age, with the rich kinds of validated data sets and validated measures and tools that we have available, you should never really feel like race is your only recourse. So you can have diversity, but you should condition on other things. So these other sort of social and individual factors, just not race.
Great. From the chat, Sabrina Poole asked, what about race as a construct when getting grants for research from NIH and or NIDA, famously known that the percentages are small? And I'll add to that, you've got NIH funding, you've had to do those planned recruitment tables by race and ethnicity and gender. And then if you had to do progress reports, you've had to report on your enrollment. So I'm curious, like how you feel filling those tables out and how the NIH can actually, if at all, do that better or differently.
Yeah, I hate those tables. I think they're useless. But and the reason why I think that they're not particularly useful is because we don't have any infrastructure to support thoughtful, proactive recruitment. Right now, for the vast majority of our clinical trials, recruitment is either reactive or ad hoc. So filling out the planned enrollment tables is pretty useless unless you have a very, very well characterized sampling frame. And again, we're sort of starting to creep towards that, with some of the new FDA guidance, maybe with some of the new regulations at NIA, where now you have to fill out sort of monthly enrollment instead of just annually. So I would say that to answer that part of the question, I don't think that they're terribly useful at this point in time. Maybe they will be in the future. But ultimately, I think the strong view that I have is that there needs to be some sort of justification for the sample that you have not matching a representative population in terms of the risk of what it is that you're studying. So that should be the planned enrollment table. And then you can match your actual enrollment versus that planned enrollment. And then you can start to explore why you're not necessarily reaching certain groups. Now, that said, I still don't think using race in those planned enrollment tables is very useful, because race is going to be a terrible mechanism of action for any sort of social disparity that you're trying to look for. So when we're talking about this question of who gets the funding, I think it's a great question to ask about race, But I have no illusions that the reason why I got, a Pioneer Award from NIA is not because like I'm like magically brilliant. It's not, in spite of me being Black. It's because I'm at Harvard. And so there is like a whole sort of like brand energy that you get from submitting a frankly bonkers grant with the Harvard stamp on it. And so I think, if I was at a different institution, I would not have been successful. But that is not reflected in like these grant success data, where you can say, all right, well, only a certain percentage of Black individuals are getting these grants. But where are those Black individuals affiliated? I'll bet dollars to donuts that they have some sort of a particular affiliation with institutions that either have like a special influence in that particular topic of exploration, or they are, well connected with the team that's designing the particular award. So I would say that, again, thinking about race in terms of who's receiving the NIA awards or NIH awards is an interesting beginning. I would say it's not particularly useful, but it can start to help you explore some of those social factors underpinning racial identity. And I think that is what NIH should be trying to intervene on, because it's not necessarily that, you want only like, rich Black doctors at Ivies to get all of the NIH awards. You want to spread the wealth so that, talented Black or minoritized or, women or non-binary individuals are competing for awards in a true meritocratic sort of system. So, again, what we have to recognize is that race is available, but that doesn't make it right. And race is available, but that doesn't make it specific. And so, whether we're talking about who's receiving awards or the planned enrollment tables, it is a crude measure at best of the social order. And so I just really challenge us to try to do more and to kind of look beyond that one single marker of social identity to try to understand, where our money is going. Yes.
Hi. So I am just curious. So we've said earlier that there's not really SOPs or like standard operating procedures with like community engagement and
Yes.
recruitment and that kind of thing. So I'm just curious, like I know this is broad, but is there a way that can be implemented? Like, is that just institution by institution, or how, like, to me, it seems like that should be something that is like in every institution, and that's just the normal procedure. But
Yeah, so if you think about any sort of SOP that you have in your research lab, in most cases, those were developed by people in that lab when that lab was first established. So unfortunately, although this should be done at an institutional level or a community level, it really should be. For the time being, it likely won't. So you're probably going to have to rely on those same mechanisms that you've leveraged to develop standing operating procedures or best practices within your team to extend it out beyond the pre-screening level and start to build standard and best practices around elements of engagement, raising awareness, advertising. Usually, a lot of these things are naturally assumed. So back at Mass General, if you talk to anybody in the psychiatry department, for example, all of them advertise on the red line of the MBTA, of the subway. And that's just what they do in psychiatry. Nobody else does it. It's only that one department at the hospital. And so there are lots of these assumptions that are sort of baked in that can usually help you form kind of the early parts of the standard operating procedure. But as a scientist, you should be interrogating these questions at every stage. Yes.
I'll give you one from the chat. We may have room for one or two more. From Pamela Price, what are some ways to better engage communities to improve the data sets available for research?
Oh, okay. So hello, Pam. Glad to see that you're here. So I'm going to give the answer that I know Pam wants me to say, which is that we should be, and this is the kind of the point that I was offering yesterday, which is that we should be decolonizing science. And that is not as scary a term as it sounds. I promise it's actually not that scary. What it means is that we need to build in room for more flexibility and more kinds of expertise at all levels of our research studies. It is really just that simple. So recognizing that the way that we currently set up our studies, where usually like a single or a small team of very, very narrowly trained principal investigators are responsible for all aspects of decision-making, is wildly unrealistic because most of us never get any training for any of it. And so that's why we do a terrible job. So opening up for other kinds of expertise, not just for sort of administration, but for engagement and for interpreting data and contextualizing information is the best way that we can get more community individuals involved. So people are always saying, you know, we need more diversity at leadership levels, but gosh darn that pipeline. You know, screw the pipeline. We don't need a pipeline. We just need to recognize that there are people who have the expertise that we need and build in space for them within our research teams as they are. So we don't need everybody to go through medical school or graduate school. We just need to recognize that there are other kinds of expertise that we as researchers are not prioritizing. So pay people for their time, bring them onto your team. You don't have to worry about a pipeline. You'll have more of that diversity that you need. And you as a researcher will have more highly contextualized data that you can then return to the community. The other thing that I want to say is that researchers should not own the data. So that might feel a little more controversial. I don't think we as researchers should own the data. It's a deeply colonialist model, and I don't think it's going to really buy us much more innovation for much longer.
All right.
Are we out of time? We're out of time.
We are.
I'll stick around if people have some
Jonathan will be
questions.
around a little more. Thank you all for joining us. Everyone online.